Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing some of the important clinical based questions in the endocrinology. So the first question, if we see, we have a 35-year-old female presented to the emergency department with 1 week history of the generalized weakness, fatigue, and as well as the weight loss. She reports increased pigmentation on her skin and craving for salty food. On examination, her blood pressure is low, that is 90 by 60, and she appears hyperpigmented. Laboratory investigations reveal hyponatremia, hyperkalemia, and low plasma cortisol levels with an elevated plasma adrenocorticotropic hormone, that is ACTH levels. Which of the following is true about the drug of choice for treatment of this disease? First option, that particular drug exhibits high mineralocorticoid to glucocorticoid. It exhibits low mineralocorticoid to glucocorticoid, and it exhibits equal mineralocorticoid and glucocorticoid activity, and it exhibits a potent glucocorticoid activity only. So first of all, what is this clinical scenario suggestive of? So this clinical scenario, it is suggestive of the addisons, right, which is nothing but the primary adrenocortical insufficiency. So what are the points to tell that it is addisons? So due to cortisol deficiency, the individual will have weight loss, there will be fatigue, and as well as generalized weakness. And it is mainly because of increase in ACTH, which is given in the question. Accordingly, there will be increase in the MSH as well, and that will predispose to the increased pigmentation of the skin. And due to aldosterone deficiency, there will be sodium loss, and thereby the individual will be craving for salty food, and they will be also having hypotension, which is given in the question, where the blood pressure of the individual is only 90 by 60 millimeters of mercury, right? And this particular individual is also having hyperkalemia. Now what could be the reason for hyperkalemia? It is again because of the aldosterone deficiency. So there is cortisol deficiency, there is aldosterone deficiency, and there is increased ACTH. So all these are the points suggestive of the primary adrenocortical insufficiency, which is nothing but addisons. And in case of addisons, the drug of choice is the hydrocortisone. So if you take this hydrocortisone, why are we giving hydrocortisone? Because the hydrocortisone is that particular drug which exhibits equal mineralocorticoid and glucocorticoid activity. Because in primary adrenocortical insufficiency, both glucocorticoid and mineralocorticoid is reduced. So you need to give a molecule or a drug which has the dual activity. And hydrocortisone is having both glucocorticoid and as well as the mineralocorticoid activity as well, right? Whereas you take in case of the secondary adrenocortical insufficiency. What is the drug of choice for secondary adrenocortical insufficiency? That will be dexamethasone. Because secondary adrenocortical insufficiency is that where dexamethasone, right? Secondary adrenocortical insufficiency is that where the pathology is within the pituitary gland. There will be decrease in the ACTH levels. And because of decrease in ACTH, you will have only decrease in glucocorticoids, but the mineralocorticoids or aldosterone levels will remain normal. So that is the reason why dexamethasone is considered, and dexamethasone is what? It's a potent glucocorticoid, and it does not have much of the aldosterone activity. So that is the reason why dexamethasone is considered as the drug of choice in case of the secondary adrenocortical insufficiency. For primary adrenocortical insufficiency, it is hydrocortisone. For secondary adrenocortical insufficiency, it is the dexamethasone. So if you take the clinical features of the addisons, due to glucocorticoid deficiency, the individual will have hypoglycemia, lack of energy, weight loss, muscle and joint pain, anemia, lymphocytosis, and eosinophilia. Due to mineralocorticoid deficiency, they will have postural hypotension and dizziness, salt craving, hyperkalemia, and hyponatremia. And due to sex steroid deficiency, these individuals will have lack of energy, dry and itchy skin, loss of libido, and loss of the axillary and as well as pubic hair. And due to excessive increase in the ACTH, right, that will cause parallelly increase in the MSH as well, and that will predispose to the hyperpigmentation of the skin and as well as mucous membrane. So if you take this particular mnemonic, that is addisons. What is the most common cause of addisons? It is autoimmune destruction of the gland in the West. That is the most common cause, that is A. D stands for decrease in aldosterone, decrease in cortisol, and as well as decrease in weak sex hormones as well. So D stands for dihydroxyepiandrosterone acetate, which is a weak sex hormone that is reduced. I stands for the increased water intake, right? Why is this the increased water intake in these individual is because there is the sodium and water being lost in these individuals. So hypoglycemia will be there due to cortisol deficiency. The output of the urine is increased. There will be polyuria, that is because of aldosterone deficiency. Sodium levels are decreased due to aldosterone deficiency, and hyperpigmentation will be there due to increase in the ACTH levels. And as the ACTH levels increases, there will also be increase in the MSH as well. Then next is this SE stands for the loss of libido and erectile dysfunction due to loss of the weak sex hormones. And this AS stands for what is the investigation of choice? That is ACTH stimulation test. That is the investigation of choice, right? Which is also called co-syntropin test, which is also called short synactin test. And lastly, the E stands for the evaporation of water. So what exactly is the drug of choice in these patients? Hydrocortisone is the drug of choice in these patients with the addisons. So if you see this particular table here, that is hydrocortisone. Hydrocortisone, it has 1:1 glucocorticoid and mineralocorticoid activity. Whereas you take this dexamethasone. Dexamethasone, it is having a potent glucocorticoid activity, but mineralocorticoid activity is not there for dexamethasone. So dexamethasone is the drug of choice in case of secondary adrenocortical insufficiency, whereas hydrocortisone is the drug of choice in case of the primary adrenocortical insufficiency, right? Now, followed by that, the second question, we have a 32-year-old male with history of severe asthma presents to the clinic complaining of the worsening symptoms. He has been prescribed oral corticosteroids for the past 3 weeks. On examination, you note his round face, central obesity, and thin skin with stripe. He also reports easy bruising and poor wound healing. Laboratory investigations reveal elevated blood glucose levels. Which of the following measures is the most appropriate to avoid the mentioned complications in this patient? The options are increase in the dose of the oral corticosteroids for better control of asthma, switching to long-acting corticosteroids for a sustained effect, divide the daily corticosteroid dose into multiple administration throughout the day, gradually taper the corticosteroid dose when discontinuing the treatment. So this particular individual is having severe asthma and presenting to the clinic due to worsening of the symptoms. So he has been prescribed oral steroids for almost 3 weeks, and because of which he has developed the features suggestive of the Cushing's. So now what is that you need to do to the steroids? Once the individual develops the iatrogenic Cushing's, you need to gradually taper the corticosteroids when discontinuing them, because when the individual has taken the steroids for at least more than 1 week, abrupt cessation of the steroids can cause the HPA axis suppression, because when the individual is on steroids, the hypothalamo pituitary adrenal axis is being suppressed. So once you abruptly stop the steroids, the individual will have the acute adrenal insufficiency. So that is the reason why abrupt cessation of the steroids should not be done. So you need to gradually taper the steroids and then discontinue the treatment. So that is what you need to follow in this patient. So next question. A 65-year-old postmenopausal woman presents with history of multiple fragility fractures over the past few years. She reports a sedentary lifestyle. Her physical examination is unremarkable except for loss of height. DEXA scan reveals low bone mineral density. Laboratory investigations show normal calcium and as well as the phosphate levels. Serum 25-hydroxy vitamin D levels are within the normal range. Which of the following best explains the mechanism underlying the development of the underlying disease in this patient? So the options are increased osteoclast activity and bone resorption, defective mineralization of the bone matrix, impaired collagen synthesis, reduced osteoblast function, and the bone formation. So postmenopausal women, right? So what is the scenario? The scenario is postmenopausal women presenting with multiple fragility fractures. So what exactly is this suggestive of? This is suggestive of the postmenopausal osteoporosis, right? Postmenopausal osteoporosis. Now, this particular osteoporosis, it is characterized by reduced bone mass, right? So it is characterized by reduced bone mass, right? And this reduced bone mass, it is mainly due to reduced osteoblastic function and as well as the bone formation that you observe in the postmenopausal state. So in the postmenopausal state, there is decrease in the estrogen levels, and that particular decrease in the estrogen levels is the one which will be responsible for reduced osteoblast function and as well as the bone formation. So these particular osteoblasts, they are responsible for the synthesis and deposition of the bone matrix, and the osteoblasts, they are required for the deposition of the bone matrix including collagen and other components which are necessary for the bone mineralization. So inadequate, right, reduced osteoblast activity leads to decreased bone formation, right? Inadequate osteoblast activity leads to decreased bone formation and results in low bone density, right? Results in low bone density. Whereas you take the first option, that is increased osteoclastic activity and bone resorption. See, increased osteoclastic activity and excessive bone resorption can contribute to bone loss. And this is not the primary mechanism in case of the postmenopausal osteoporosis, right? And estrogen deficiency after the menopause leads to imbalance between the bone formation and as well as the resorption. So it is not because of increase in osteoclastic activity there is postmenopausal osteoporosis. It is mainly due to reduced osteoblast function. And you take the second option, defective mineralization of the bone matrix. See, defective mineralization of the bone matrix is associated with conditions such as osteomalacia and as well as rickets, where there is impaired mineralization of the osteoid matrix. That is what is your second option, not in case of postmenopausal osteoporosis. Impaired collagen synthesis. See, collagen provides the structural framework for the bone, and the collagen provides, if there is like collagen deficiency, that will lead to the brittle bone, right? That will lead to brittle bone, and that is what you observe in disorders like osteogenesis imperfecta. That is what you observe in the disorders such as the osteogenesis imperfecta. However, in case of the postmenopausal osteoporosis, the primary defect is reduced osteoblast function and bone formation rather than the impaired collagen synthesis. So impaired collagen synthesis is the feature of the osteogenesis imperfecta, right? So the answer here is the fourth option, that is D. And coming to the next question, we have a 60-year-old postmenopausal woman with history of osteoporosis presents with complaints of bone pain and a recent fracture. So she has been prescribed a medication that inhibits the osteoclast activation and causes the osteoclast apoptosis. This drug is known to inhibit the vital enzyme, that is farnesyl pyrophosphate, in the mevalonate pathway. So which of the following side effects is commonly associated with this medication? Nephrotoxicity, gastritis and esophagitis, osteonecrosis of the jawbone, and then the hypocalcemia. So what is that particular drug which will cause the inhibition of this vital enzyme, that is farnesyl pyrophosphate, in the mevalonate pathway? This particular drug is nothing but bisphosphonate. Okay, so it is bisphosphonate. And what are the examples of the bisphosphonate? That includes alendronate, that includes risdronate, that includes palmidronate, and that includes zolinronic acid. And these bisphosphonates are administered intravenously. So route of administration of this particular drug is the intravenous route of administration. And these bisphosphonates, they work by inhibiting the osteoclast activation, right? They work by inhibiting the osteoclast activation and they cause the osteoclast apoptosis. Okay, they cause the osteoclast apoptosis. And this particular bisphosphonates are the one which will inhibit the farnesyl pyrophosphate, right? They inhibit the farnesyl pyrophosphate, which is the important enzyme in the mevalonate pathway, right? And among the various adverse effects which has been given, it is the osteonecrosis of the jawbone. That is the most common adverse effect which is associated with this bisphosphonate. Whereas nephrotoxicity can occur with intravenous administration of the zolinronate, but it is not common. right? So it is uncommon. Nephrotoxicity is uncommon. Then gastritis and as well as the esophagitis. These are the adverse effects that occur when bisphosphonates are administered orally, right? So when bisphosphonates are administered orally, then you will have this gastritis and as well as the esophagitis, right? So however, what is the information given to us? That particular drug is given through the intravenous route. Okay, the drug has been given through the intravenous route, right? And the next important is the hypocalcemia. See, hypocalcemia, it is not the direct side effect of the bisphosphonate. In fact, bisphosphonates increase the risk of the hypocalcemia if excessive bone resorption occurs, but it is not a common associated side effect with bisphosphonate. So among the options which has been given, the commonly associated adverse effect with the bisphosphonate is the osteonecrosis of the jaw. So let me tell you a few more points about the bisphosphonate. The mnemonic is bisphosphonate. So this is one of the best drug for the osteoporosis. That's a drug of choice, mainly in case of primary hyperparathyroidism. I stands for, it is given through the intravenous route, and it causes intertrochanteric fractures. S stands for stops or inhibits the osteoclast activation. P stands for used to treat the Paget's disease of the bone. H is used to treat the hypercalcemia of the pregnancy. O stands for it causes the osteonecrosis of the jaw. S stands for causes stomach problems when it is taken orally, that is gastritis. PH stands for inhibits the farnesyl or farnesyl pyrophosphate. Onate, right? What are the examples? That is zoledronate, risdronate, and as well as the alendronate. So this will be some of the important additional points related to the bisphosphonates. Coming on to the next question, we have a 65-year-old postmenopausal woman with history of osteoporosis presents for the treatment. After a thorough evaluation, the physician decides to prescribe medication that acts as an anabolic agent and forms the bone. This medication is administered subcutaneously and it is primarily used in severe cases of the osteoporosis. Which of the following medication fits the described description provided? Teriparatide, denosumab, bisphosphonates, and then the calcitonin. So see, it is an anabolic agent, right? And this medication is administered subcutaneously and it is primarily used in severe cases of the osteoporosis. So what is that molecule? That molecule is the teriparatide. So teriparatide, it is a recombinant parathormone. Okay, it's a recombinant parathormone and it's an anabolic agent, right? And this teriparatide, which is a recombinant parathormone, it is made up of 1 to 34 subunits. So it is made up of 1 to 34 subunits and it is not a complete parathormone unit. And what is the route of administration of this teriparatide? It is administered via the subcutaneous route and it is prescribed only in severe cases of osteoporosis, right? However, this teriparatide, it is associated with some important considerations and potential adverse effects. And one of the notable adverse effects of the teriparatide is hypercalcemia. So hypercalcemia is one of the notable adverse effects associated with the teriparatide, right? And the prolonged use of the teriparatide exceeding 2 years has been associated with increased risk of the osteosarcoma, right? So if it is being used for more than 2 years, it is associated with the increased risk of the osteosarcoma, right? And that osteosarcoma is mainly due to the stimulatory effect on the osteoblast activity. That is the reason why this teriparatide has been given as a black box warning if it is being used for prolonged time. Whereas you take this denosumab. Denosumab, it's a monoclonal antibody against rank ligand. And this will inhibit the activation of the osteoclast and it is not anabolic agent. That is the reason why denosumab is not the correct option. Bisphosphonates, if you see the mechanism of action, it inhibits the osteoclast activation and it causes the osteoclast apoptosis. And what is the route of administration of this bisphosphonates? it is administered through the intravenous route or it is given via the oral route. So that is about the bisphosphonates. Whereas you take this calcitonin, calcitonin is used to manage the conditions such as the hypercalcemia and osteoporosis. And what is the route of administration of this calcitonin? It is administered through the intranasal route. Right, so it is administered through the intranasal route and it is commonly used in the postmenopausal osteoporosis, but it is not an anabolic agent. So the answer here is teriparatide, which is an anabolic agent. So like if you take the various drugs which are used in the treatment of the osteoporosis, like we have the bisphosphonates, the route of administration is oral or intravenous. Denosumab, the route of administration is subcutaneous. Teriparatide, the route of administration is also subcutaneous. And raloxifene, it is a selective estrogen receptor modulator which is used in postmenopausal osteoporosis. The route of administration is oral. And next is romosozumab, the route of administration is the subcutaneous and it targets the sclerostin produced by the osteocytes. And the other molecule is the calcitonin. It inhibits the osteoclast activity and the route of administration is the intranasal. And the other important molecule is the strontium granulate, the route of administration is oral. The estrogen or the hormonal therapy, the route of administration is oral or transdermal. So this is about the various drugs or various molecules which are used in the treatment of the osteoporosis, right? So coming on to the next question. We have a 25-year-old male presents with painless lump in the posterior neck that has been gradually increasing in size. Physical examination revealed a firm, non-tender thyroid nodule. The patient also reports a family history of similar thyroid nodules and medullary thyroid carcinoma. Laboratory investigation showed elevated serum calcitonin level. Further evaluation revealed bilateral adrenal masses on imaging. Which gene is most likely responsible for this patient's condition? RET proto-oncogene, TP53 gene, BRCA1 gene, and then the APC gene. Okay, so this patient is having medullary carcinoma of thyroid and this patient is also having bilateral adrenal mass, right? So what is this suggestive of bilateral adrenal mass? It is suggestive of, the pheochromocytoma. So presence of medullary carcinoma of thyroid and as well as the pheochromocytoma, that is MEN2 syndrome. MEN2 again, we have 2A and as well as 2B. So you take 2A. So 2A, right, the mnemonic is PAT. What does this PAT stands for? P, that is the pheochromocytoma, or okay, the word P stands for parathyroid adenoma. A stands for the adrenal pheochromocytoma. T stands for thyroid abnormality. Right, and what is that thyroid abnormality? Medullary carcinoma of thyroid. And in case of 2B, that P is not there, only adrenal pheochromocytoma and thyroid. So whatever the clinical scenario which has been given to you here, it is suggestive of the MEN2B. So in case of MEN2B, what is the gene that is being mutated? That is RET, that is RET proto-oncogene that is being mutated. So in all MEN2A and MEN2B, it is the RET proto-oncogene that is being mutated, right? Whereas you take this TP53 gene. TP53 gene, it is associated with the development of Li-Frommani syndrome, right? It is associated with Li-Frommani syndrome, and this TP53 is characterized by increased risk of various malignancies. So what are the various malignancies that you observe with the Li-Frommani syndrome is sarcoma, breast cancer, brain tumor, right? So this TP53, it is not directly related to MEN2 syndrome. Then if you observe the BRCA1 gene. So BRCA1 gene, it is associated with hereditary breast and the ovarian cancer syndrome. So breast malignancy and ovarian malignancy, you have the BRCA1 gene, right? Whereas you take this APC gene. The APC gene is associated with the development of familial adenomatous polyposis. And this APC gene, it is this familial adenomatous polyposis, it is an inherited condition characterized by the development of multiple polyps in the colon and rectum, right? Multiple polyps in the colon and rectum. And this APC gene, it is not associated with the MEN2 syndrome, right? Whereas you take all the MEN syndromes. So we have MEN1, MEN2A, MEN2B, and as well as MEN4. So MEN1, right? That is MEN1 gene. It's a tumor suppressor gene, and another name for MEN1 is, it is also called the Wermer syndrome. Then you take MEN2A and MEN2B, the gene that is being mutated is RET, and MEN4, the gene that is being mutated is CDKN1B, right? And this MEN1 gene, it is present on chromosome 11, and RET proto-oncogene, it is present on chromosome number 10, and CDKN1B, it is present on the chromosome number 12. So this is about the genes that are being mutated in case of the MEN syndromes, right? So this is about the question related to MEN syndromes. Next question is, we have a 40-year-old female presents to the endocrinology clinic with history of reduced kidney stones and fatigue. She also reports the symptoms of constipation and occasional abdominal pain, and laboratory investigations reveal elevated serum calcium level and decreased serum phosphate levels. Imaging studies show a solitary parathyroid adenoma. The patient is also found to have the pituitary adenoma. Given the clinical features and imaging finding, which of the following findings can be seen in this patient? Increased serum gastrin levels, elevated serum cortisol levels, hypokalemia, and impaired liver function. So these features you see here, recurrent kidney stones. What could be the reason? Hypercalcemia, right? So hypercalcemia can also cause constipation, and there can also the abdominal pain, and there will be elevated calcium and decreased phosphate. So this elevated calcium and decreased phosphate, it is suggestive of hyperparathyroidism. Okay, next, the individual is also said to be having the pituitary adenoma. So parathyroid, that is hyperparathyroidism, that could be secondary to parathyroid adenoma, and then pituitary adenoma. So the question asks, like, which of the following can be the finding in this patient, the additional finding. So please remember 3 P's in case of MEN1. What are the 3 P's of MEN1? Parathyroid adenoma, then the pituitary adenoma, then the pancreatic tumors. Right? Then pancreatic tumors. The most common is the parathyroid adenoma. Right? The most common is the parathyroid adenoma. Now, in case of the pancreatic tumors, what are the various pancreatic tumors? We have gastrinoma, insulinoma, then glucagonoma, somatostatinoma, pancreatic polypeptidoma. So this particular patient is associated with increase in serum gastrin levels, and that is secondary to the pancreatic adenomas or secondary to the pancreatic tumors. Okay, so this clinical picture is suggestive of MEN1, that is multiple endocrine neoplasia type 1. So if you take this MEN1, you have parathyroid, pancreatic, and pituitary adenoma. Whereas in MEN2A, that is medullary carcinoma of thyroid, pheochromocytoma, and parathyroid adenoma. Whereas in MEN2B, you don't have this parathyroid adenomas, but medullary carcinoma of thyroid and as well as pheochromocytoma, and you have extra endocrine manifestations in the form of marfanoid habitus and as well as the mucosal neuromas. Whereas in MEN4, where you have the gene mutation, that is CDKN1B, that is the pituitary adenomas, parathyroid adenomas, and reproductive organ tumors, that is testicular tumor and cervical tumors, are present in case of the MEN4. Okay, that is due to secondary to CDKN1B gene mutation. So this is about the MEN syndromes, that is multiple endocrine neoplasia syndromes. Moving to the next question, we have a 35-year-old male presents to the clinic with complaints of recurrent headache and visual disturbances. On further evaluation, the patient is found to have multiple hemangioblastomas in the cerebellum and the retina. Additionally, a retinal ultrasound reveals the presence of multiple renal cysts. The patient's family history is significant, with his father being diagnosed with bilateral pheochromocytomas. Based on these findings, which of the following is most likely diagnosis for this patient? Neurofibromatosis type 1, von Hippel-Lindau syndrome, multiple endocrine neoplasia type 1, then hereditary paraganglioma pheochromocytoma syndrome. So the individual is having the features suggestive of the pheochromocytoma, that is recurrent headache and as well as the visual disturbances secondary to hypertension. That recurrent headache is mainly because of the hypertension. And whatever the clinical picture, like multiple hemangioblastomas in the cerebellum and as well as retina, and ultrasound is revealing multiple renal cysts. So diagnosis is suggestive of pheochromocytoma, and you have to understand and you have to remember that pheochromocytoma is associated with multiple other disorders like von Hippel-Lindau syndrome. Okay, so the most likely diagnosis in this patient, whatever the clinical picture has been given, it is suggestive of the von Hippel-Lindau syndrome. So this von Hippel-Lindau syndrome, it is an autosomal dominant disorder which is characterized by development of various tumor census in multiple organs. So in case of the von Hippel-Lindau, there is presence of the hemangioblastomas, right? There is presence of hemangioblastomas in the cerebellum and as well as retina. Right, in the cerebellum and as well as the retina, along with renal cysts, and there is also family history of the pheochromocytoma, right? And this von Hippel-Lindau syndrome is associated with the development of the other tumors. Von Hippel-Lindau, it is associated with the development of the renal cell carcinoma. It is associated with the development of the pancreatic neuroendocrine tumors, and it is associated with the development of the endolymphatic sac tumors, right? Associated with the development of endolymphatic sac tumors. So these are the tumors which are associated with the von Hippel-Lindau syndrome. Whereas you take the first option, that is neurofibromatosis type 1, it is characterized by development of multiple neurofibromas, CAF-LU spots, which is not there in the question. Then you take multiple endocrine neoplasia type 1. In multiple endocrine neoplasia type 1, you don't have the pheochromocytoma at all. Then hereditary paraganglioma pheochromocytoma syndrome, right? So this fourth option, it is a genetic disorder which is characterized by development of paragangliomas and as well as the pheochromocytomas. What is paraganglioma? Paraganglioma is nothing but the extraordinary pheochromocytomas are called paraganglioma, right? So in these patients with hereditary paraganglioma pheochromocytoma syndrome, you don't have this von Hippel-Lindau syndrome manifestation, okay? So the answer in this particular question is B. So coming on to the next question, we have a 45-year-old female presents with recurrent episodes of confusion, palpitations, and as well as diaphoresis. She reports that these episodes occur mainly in the fasting state or during prolonged physical activity. She also mentions occasional episodes of visual disturbances and as well as headache. On examination, you note her blood pressure is 110/70 and her body mass index is within the normal range. Fasting blood glucose levels are consistently low while serum levels are significantly elevated. Based on the clinical presentation, which of the following is the drug of choice for the management of this patient's condition? Metformin, glucagon, diazoxide, then sulfonylureas. So this clinical presentation, it is characterized by recurrent fasting related symptoms. Okay, so the patient is having confusion, palpitations, diaphoresis, and there is also low fasting blood glucose levels. So low fasting blood glucose levels with elevated insulin, right? Low fasting blood glucose levels with elevated serum insulin, it is suggestive of the insulinoma. And insulinoma is what? It's a pancreatic neuroendocrine tumor that secretes the excessive amount of insulin leading to hypoglycemia. So what is the drug of choice? So drug of choice in this scenario is diazoxide. So diazoxide, it is the drug which is given as a medical management. What it will do? This particular diazoxide inhibits the insulin release. Right, diazoxide, it inhibits the insulin release from the pancreatic beta cells. That is the reason why diazoxide is considered as the drug of choice. Ultimately, these patients will be requiring surgical resection, but medical management will be diazoxide. Whereas you take metformin, it is an oral diabetic drug used in the treatment of type 2 diabetes mellitus. So it has no role in case of insulinoma. Then you take glucagon. Glucagon, it is a hormone that has the opposite effect of the insulin and it raises the blood glucose levels as well. And this glucagon is used in emergency situation to treat severe hypoglycemia, but this is not the drug of choice. Actually, even this can be used in the insulinoma, but this is not the drug of choice. Only in emergency situation where this diazoxide is not available, then glucagon is being given. Then you take this sulfonylureas. These are the oral hypoglycemic agents used in the treatment of type 2 diabetes mellitus, and they precipitate the hypoglycemia. So sulfonylureas are absolutely contraindicated. So if you take some important points related to the insulinoma, so this is one of the leading functional pancreatic neuroendocrine tumors. The usual age of presentation of insulinoma is around 40 to 50 years, and it is observed in MEN1 syndrome. And you need to know the Whipple's triad, where the patients will have the symptoms of hypoglycemia, there will be documented hypoglycemia, and there will be immediate relief whenever you give dextrose. The clinical features will be the features of hypoglycemia, that is frequent eating and weight gain, decreased concentration span, irritability, and rage attacks. And the tumors, if you see, the insulinoma, it is majority it is benign tumor. Diagnosis, right, it is the tumor size is less than 2 centimeters, and it is difficult to diagnose in early stages because the size is less than 2 centimeters. Whereas glucagonoma, majority of them are malignant, and glucagonomas, the size are almost 5 to 10 centimeters. So what is the imaging method by which you can visualize the insulinoma? That is by endoscopic ultrasound and somatostatin receptor scintigraphy or imaging, then the PET CT by using the radionuclide dye, that is gallium-68. And the treatment is diazoxide. So diazoxide is considered as the drug of choice. And the other molecules are octreotide or lanreotide. And in malignancy, we give this mTOR inhibitors, and the other options are chemoembolization and radiolabel somatostatin for malignant insulinoma. So these are some of the important points related to the insulinoma, right? Coming to the next question. So we have a 55-year-old male presents to the gastroenterology clinic with several months history of persistent skin rash, weight loss, and diabetes mellitus. He reports experiencing episodes of abdominal pain and diarrhea. Physical examination revealed necrolytic migratory erythema and anemia. Laboratory investigation showed elevated blood glucose levels and low amino acid levels. An imaging study reveals the pancreatic mass. The biopsy of the mass is performed, and histological examination confirms the diagnosis. The hormone primarily responsible for the clinical manifestation in this patient is involved in which of the following physiological processes? The options are stimulating hepatic glycogenolysis, breaking down glycogen and releasing glucose into the bloodstream, enhancing the adipose tissue lipolysis, breaking down stored fat and releasing the fatty acids into the bloodstream, promoting gluconeogenesis in the liver, synthesizing glucose from the non-carbohydrate precursors, inhibiting the protein synthesis in muscle tissue and preventing the formation of the new proteins. So what is this clinical picture suggestive of? This clinical picture, it is suggestive of glucagonoma. Why? Because the patient is experiencing the episodes of abdominal pain and as well as diarrhea. So in patients with the glucagonoma, there is hyperglycemia, and these individuals will develop the osmotic diarrhea. And in patients with glucagonoma, you will have this necrolytic migratory erythema, right? And it is also showing that there is elevated blood glucose levels and low amino acid levels. So all these are the points suggestive of the glucagonoma, right? So in case of the glucagonoma or like the glucagon, what is the physiological action? It promotes the gluconeogenesis in the liver and synthesizes the glucose from the non-carbohydrate moiety. The definition of the gluconeogenesis is nothing but synthesis of the glucose from non-carbohydrate moiety is what is nothing but your gluconeogenesis. So the answer is C in this particular question.